So these days, if someone comes to me and says, Dr. J, I want a plaque analysis. I want to know about my plaque. Do I have plaques? I really need to know. I just had a nice baby and I want to know that I'm going to be okay, right? So what do I do? How do I see a plaque without going inside? So I these days order a coronary calcium score because that will identify that plaque. It'll identify calcified plaques. The coronary calcium score will not identify non-calcified plaque. So again, let me just backtrack a little bit here. There's two types of plaques you have. You have fatty plaques and you have calcified plaques. Fatty plaques will eventually become calcified plaques. So if you really want to know, you need to know both kinds. Right now, we don't have that general technology available to everybody to look at plaque analysis. If you do a coronary CT angiogram, then AI can calculate your plaque volume and characteristics of that plaque. So let's say a CT angiogram. What is a CT angiogram? A CT angiogram is you put an IV in the arm, you inject some contrast. The contrast will go through the right of the heart, then your lungs, then come into your heart. As it comes into the heart, the CT scan is done, and you can see your coronary arteries filling. Okay? And then the very fancy computer will take out all the rest of the stuff, leave your arteries alone, and then AI can look at your plaque and tell you how much calcified plaque you got and how much soft plaque you got, and give you a ratio. Usually, it's about 3/4 of it is soft plaque, 1/4 of the plaque is usually calcified in most patients. In the soft plaque, the AI can also tell you whether you have low attenuation plaquing. What does that mean? So, when an X-ray goes through tissue, depending on the consistency of the tissue, you'll get black, white, gray. So when you get very dark shadows, very dark areas in the plaque, that's called low attenuation. That means that plaque in that portion of the artery is full of inflammatory cells. So that plaque is a hot plaque. That's a vulnerable plaque. That plaque is likely to rupture in the future. And if you have out of all your plaques, if more than 4% of your plaque, 4% is low attenuation, now I turn around to that patient and say, you have a lot of soft plaque. Okay, fine. But I have identified features of that plaque that you are vulnerable. That plaque can suddenly crack, and the day that it cracks, there's going to be an unpredictable blood clot that will form. It could be a minor one, it could be a major one. I just don't want it to rupture in the first place. So I'm going to do everything possible to look for inflammation in that patient to make sure that plaque doesn't rupture. And if it does rupture, I'm going to do everything possible in the blood to make sure that the blood clot is not very big. So that's how we approach it. So if you want to identify plaque today, there are methodologies to do it. A coronary calcium score is just a coronary calcium score. It is very helpful because if you have a coronary calcium score of 0, doesn't mean you don't have soft plaque. You could have some soft plaque. But because none of that got calcified, because none of that soft plaque gave rise to coronary calcification, you have a physiology where you have soft plaque, but your body is able to cycle through it and not have so much inflammation that it gets calcified. So it identifies soft plaque perhaps with characteristics that are unlikely to rupture. Why? Because if your coronary calcium score is 0, the chances of you having a heart attack or a major coronary event in the next 10 years is extremely low. It's so low, it's like less than 0.1%. Not 0, but very, very low. And the higher the coronary calcium, there's a higher the risk that something's going to happen. One day, you're going to get a heart attack or unstable angina, or you could even die suddenly, which I'll explain how all these plaques can make you die suddenly. Besides the clotting, there's other factors too. But basically, if you have a lot of coronary calcium, you have plaque. And that plaque, because you have so much calcium, it means your physiology is such that there's been a lot of inflammation. And the end result of that inflammation is calcification of that artery. So your physiology is not good. You're making too much calcified plaque. That means your soft plaques are rapidly going into hard plaque. So you better do something about this. You're not like the guy with a 0 score where his soft plaques may not become calcified because he's otherwise okay. So doing a coronary calcium score is a great start. I'll do that on that patient and see that, okay, your coronary calcium score is less than 100 is mild, 100 to 400 is moderate, and anything more than 400, you've got my attention, big time attention. Because that calcium that's built up on the calcium score doesn't tell me whether it is narrowing inside the artery or just sitting on the outside. Okay? If it's sitting on the outside of the artery and not narrowing on the inside of the artery, there's not going to be any flow disturbance. So what happens? I need to know whether that 400 or 300 or 200 plaque or more is narrowing inside the artery. Is your plaque occlusive or not? What's the next step? Well, it gets a little technical here. You can do a stress test because a stress test will tell me whether you have narrowing that is causing a flow disturbance. So let me explain. In a stress test, it'll pick up a blockage that's more than 70% because that's where it starts reducing the blood flow. So you fail your stress test. Yes, that blockage showed up on your stress test. It's a flow limiting lesion. If it is a flow limiting lesion, you've got to do something about that. Why? Because you can't be running on your treadmill and not getting enough blood supply because you can get an arrhythmia. You can also, if you don't get an arrhythmia and die, you're going to get left ventricular dysfunction, which means that your heart muscle is not going to work very well because it's just constantly not getting enough blood supply, and you could run into congestive heart failure. So you want to get rid of that blockage. And how? A mechanical problem requires a mechanical solution. So if you have a tight blockage, you either put a stent in it or you bypass it because it's flow limiting. It's a mechanical problem. I can't tell you that you got a mechanical blockage and say, yeah, all my supplements, here's my lifestyle, I want you to do X, Y, Z. That's not going to solve the problem. That's why I get so excited as a cardiologist, because if I was only looking at the prevention aspects of it, then I'm missing a whole part of it. That, wait a second, this patient's got a flow limiting lesion. So I'm so blessed that I'm actually able to go in, fix that blockage, and then say, okay, now let's see what we can do about your non-occlusive plaques, what we refer to as non-occlusive plaques, right? So the CT scan that we do on people, the CT angiogram, I told you it can look at plaque analysis. That is an AI-driven program. And it'll tell you how much soft plaque you got, the volume in each of your 3 arteries, and it'll tell you about the characteristics of your plaque, whether it is calcified, and the soft plaque, whether it is very low attenuation or not. The angiogram portion of it, where the dye goes into the artery, can tell you how narrow it is. Now comes another technology that is so exciting, that really changed things in the last couple of years, and that is called FFR. So FFR, it's called fractional flow reserve. So it's very important that people who are interested in coronary artery disease must understand what FFR is. If you don't understand FFR and you got coronary artery disease, you have a problem. You better understand it today. So fractional flow reserve, what does that really mean? It started in the cath lab where there's a narrowing. And you look at the angiogram and you say, oh yes, I can see a blockage. It's not 90. It's not 80, it's around 60, 70, maybe 80. I'm not sure whether this is actually limiting flow or not. And I don't have time to do a stress test. So what am I going to do? So we took this pressure wire and you pass the lesion, measure the pressure beyond, and then you do a pullback. Very, very simple, right? Sounds very simple. If there's a step down, that means you know that there's low pressure on this side, there's high pressure on this side. You work it out, and that's called the FFR fractional flow reserve. And if it's less than 0.8, that means there's a significant drop in the pressure on the other side. So this is a hemodynamically significant lesion. Studies have been done that if you then open that blockage up, you get much better results because you are stenting hemodynamically significant lesions. So the FFR started in the cath lab to determine which blockages are actually causing flow limitation, which ones are not, rather than just doing an angiogram and looking at it and guessing that, oh yeah, you got a blockage there, it's 80%, and I'm just going to stent every blockage that you got. Because we did that. We did do that. And we found that the more metal we put in the patients, the more stents we put in them, the worse the outcome was. It wasn't very good. You only want to stent the lesions that are hemodynamically significant. And FFR has allowed us to do that. A positive nuclear stress test allows us to do that. So this same technology of FFR now with AI has come into CT angios. So with the CT angiogram, once you get the images, you send it off to a company that calculates the FFR. Right now, it's a company called HeartFlow. And I send off the discs to them, and they look at that, and the AI calculates the FFR, and the correlation is with invasive cardiac catheterizations, and it's extremely good. So, of course, the quality of the study has to be good too. So there are, I would say, at least about 20% of the times, it's the quality of the CT angiogram may preclude a FFR determination. So then I have to find another way to determine whether there's flow-limiting lesions or not. But AI calculates the FFR, and then the report comes back to me say, yes, there's a blockage. It looks like it's about 70, but the FFR is abnormal. Or it looks like it's 70, but the FFR is negative. So that's another piece of information that tells me about flow limitation due to the plaque. Because we're talking about the plaque. This plaque stuff is terrible. It ruptures, it obstructs, it's unpredictable. So this is another technology, FFR. So you have your stress tests, invasive FFR, and a CT FFR that can tell me all this right here in the office, right here. Technology has just come so far. Of course, a lot of the insurance companies are still a couple of decades behind the times. So it makes it difficult for the patients, but those who really want to know can get this done. It does sometimes mean they have to go outside the insurance because not all the insurances want to pay for plaque analysis, nor do they want to pay for the FFR. But relatively, it's pretty inexpensive. So we do have that technology of FFR. So let's say that fellow comes to me and he says, I turned 40, I have a little baby at home, and tell me, I'll do the coronary calcium score. If it is abnormal, if it's high, I'm going to do a CT angiogram. That's going to tell me plaque analysis, FFR, narrowing of the arteries, and I can be able to sit down with the patient and say, this is what you got in terms of your plaque. Now, that's just part one of your workup. Don't think it's over. Just because you did a anatomical study looking at your coronary arteries and looking at your plaque, there's a whole biochemistry which I'm going to dig into in just a second, because this just tells me the consequences of your plaque.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not